Thanks, Nick. Can you hear me and can you see my screen in presentation mode?
We're hearing you and we're seeing your slides beautifully, sir.
Goodness me, I had a mild panic there as I was doing that, realizing I didn't know how to unmute myself. I don't use Zoom enough. Thanks very much for having me, Debs, and the team at Ortus. It's great to be here. As Nick has said, I'm going to talk to you briefly this evening about what we've done in terms of a structured titration and rapid treatment for heart failure, or a rapid titration service, me working as a heart failure consultant at St. Bart's Hospital and as a clinical lead for heart failure at UCLH, which has allowed us to really blend what we're doing across two integrated care services. For those of you who aren't heart failure clinicians on the call, it always amazes my colleagues when I present this information that these are the things that we're asked to do in a heart failure pathway. So the new patient coming in to our services via a 2 or 6 week appointment via breathlessness pathway with an elevated NT-proBNP, or an increasing request in the international literature that we follow patients up at 2 weeks after a heart failure admission, or this third area where we are seeing people on a 6-monthly basis to provide input predominantly for those for heart failure with reduced ejection fraction. Now, I'm expecting that with the next iteration of the NICE guidelines, that may well change a bit, and we will move away, hopefully, from echocardiography on a very frequent basis to free up some of that time for mavacamten usage, and instead use NT-proBNP. There's been a need in terms of workforce strategy to think about which parts of these pathways need to be delivered by consultants and how much is delivered by allied health professionals. And with an increasing group of people who are around, because we have drugs that are doing better, that instead of having 50% mortality at 5 years in heart failure with reduced ejection fraction, we are now seeing patients coming back to see us on a regular basis and are able to keep things stable. And we've certainly seen in our services a significant reduction in referral for transplants and also for defibrillator implantation. But of course, that's what we need to do, is get these drugs to maximum tolerated doses as quickly as possible to reassess things at 3 months with an echocardiogram and ECG and think about devices. Now, in the real world, even with utilizing our community heart failure teams, we don't achieve this quickly. STRONG-HF is a clinical trial published in The Lancet showing that versus usual care, if you take a group of individuals who have been an inpatient, are on roughly 50% dose equivalents of all 4 pillars, that they do better with fewer symptoms, improved quality of life. This was safe and well tolerated. It's important to recognize that this happened across COVID-19, and so deaths relating to COVID were excluded. But you see this big difference in mortality with an early separation of the curves at just 90 days. But we don't achieve that. If you think about most hospitals in terms of meeting a 2 and 6 week pathway for new patient referrals, it doesn't happen. Our community services are overwhelmed. We have increasing patients with PEF, and therefore the next appointment across the 5 hospitals involved in what we've done is 2 months in our shortest waiting time. And so realistically, it takes 12 to 18 months to get patients onto drugs in an NHS setting where we've got lots of resource at St. Bartholomew's Hospital. So we thought about a rapid titration service when it came to the heart failure targeted funding round of 23-24. We were lucky that Debs had run a pilot at Whipps Cross that he presented at ESC Heart Failure in 2024 with the whole team involved. And what we did was take that and standardize what we would do for inpatients like STRONG-HF, but also for outpatients for the first time in our local area, have them seen by a heart failure team, and then refer them to a structured titration that would happen rapidly. This would be all supported with Ortus through appointments. They would spend 30 minutes on the phone understanding heart failure with our pharmacist, agree to upload their hemodynamics and weight, as well as fill out symptom questionnaires relating to dizziness, NYHA class, quality of life. And we aimed to have 6 weeks of patient-led titration, meaning that patients would put that information on a daily basis. And we were hoping that twice a week, our pharmacist would be able to touch base in order to titrate. And then at the end, a 15-minute phone call with a booked appointment to happen across our 5 hospital sites at 3 months to make a decision about devices. This was ambitious. We started small, but what we quickly realized was that we needed to take advantage of what was possible through Ortus. We were facilitating blood tests at a local hospital. We were using a system called Clio to deliver scripts directly to local pharmacies in order to allow patients easier access. And in order to keep everyone up to date, we weren't creating admin. Our letters were being emailed directly from Ortus out via AccuRx to the GP and uploaded onto the London Care Record. The idea of all of this was to think about key KPIs of safety, quality of life, and patient satisfaction. We were hoping that if everything was up and running, a single pharmacist could deliver 24 new onboards a week and 36 offboards a week. We quickly realized that that was going to be tough as we first started. But what we wanted to focus on was mortality and readmissions, improved quality of life, and rapid access to devices for patients. But as a trust, or two trusts, or 5 hospitals for us, better outpatient slot utilization, less duplication, an echocardiogram that was being able to make a decision rather than several echocardiograms along a patient journey trying to make a decision about drugs and devices, and of course the financial implications. So since September of 2024, we've onboarded 160 patients and discharged 111, and it has been a phenomenal learning curve, but really enjoyable. Roughly 1/3, 2/3 inpatient versus outpatient across 5 hospital sites, again across 2 hospital trusts and across 2 ICBs. Typical for heart failure, 73% male in their 60s. We have been working hard to make sure we maintain equity across our cohort, so 52% non-white British, the Charleston index indicating moderate comorbidity, and all of our patients sitting in the highest quintile when considering index of multiple deprivation calculated based on postcode. We've got better at it. So when we first started and looked at this data in our monthly dashboard, it was taking us 10.5 weeks. We're now down to 8.6 weeks, roughly 6 appointments. And those are touch points delivered via message to increase a dose based on a patient giving us blood pressure, heart rate, and telling us whether they're dizzy or not. The patients have loved it. Our pharmacists are extremely popular when patients come back to see us in clinic. Does it work? Well, actually, the data is phenomenal. Huge reductions in NT-proBNP, which to me are clinically meaningful. And at 3 months, we're obviously behind, but ejection fraction in 51 patients have shown that we are using far less echocardiography when we look at the same period of time over the last 2 years. Average or mean ejection fraction at presentation is 30%, as low as 7%, up to 45% at 3 months. And what that, of course, means is that 50% of our patients have been able to be discharged from a heart failure clinic at 4 months from their diagnosis under a PIFU pathway, which, of course, has led to dramatic reductions in our waiting times. And we've made the decision that 13 patients have needed an ICD much, much faster than we would have otherwise seen. These are the data for ACE, ARNI, beta blocker, MRA, and SGLT2 inhibitors. The lighter color at admission, the darker color at discharge. So 92% on all 4 pillars, 0 readmissions across the last 9 months, compared to 25% across all 5 hospitals. And when we look at dose equivalents, what we're doing is we are achieving this quickly. We are getting people onto huge doses of ARNI. We are allowing them to tolerate MRAs in ways that we do not see in the National Heart Failure Audit. SGLT2 inhibitors are not for all, and for the heart failure clinicians on the call, you will know why I say that. But what's been really interesting is that because of the licensing agreements and SPCs looking at the drugs, by the time we have blood tests to do the potential renal injuring drugs, although we all know they don't actually do that, beta blockers are not required. Their resting heart rates have come down. And so most of our patients are discharged on 5 milligrams or less of bisoprolol. We've saved 659 appointments for those 111 patients and pulled them out of traditional follow-up. Our waiting times are now closer to 2 months, 6 to 8 weeks, rather than 4+ months. And this is having a huge impact environmentally and for patients. They're saving more than 2 hours of travel time. 3.8 tons gets you a round trip across the world, or 2.5 houses in the UK funded for their annual electricity bill. And it's safe. No unplanned admissions, We've had 3 patients started on Localma that they picked up directly from their hospitals, from their local pharmacies. And with 6 admissions, none of them have been related to what we've done. And this was an unintended consequence. Our pharmacists have recognized that overnight, hemodynamics have become very abnormal. Patients have an early way to get in touch. And we've had, therefore, 1 patient admitted with an acute kidney injury that led to a new diagnosis of bowel cancer, a pulmonary embolus, and 4 patients with sepsis who've gone to hospital on instruction from our pharmacist within 12 hours of symptoms. But it isn't for everyone. Not everyone has a smartphone. We're working through one of Debs's MD students on thinking about language and other barriers. You can't rapidly titrate if you've got a Dosset box or a blister pack. And some patients just do not understand the importance of what we're seeing here and have gone back to their local teams in order to follow a more traditional pathway. So I think what we've seen is that we will, over the next 12 months, see a reduction in mortality. We've seen it in readmissions. Patients report improved quality of life via the Minnesota Living with Heart Failure questionnaire. And we are absolutely revolutionizing what we're doing in terms of echocardiography and outpatient slot usage. So from a trust perspective, this has all gone down very, very well. And we are now have our ongoing funding from the North East London ICB, which we're, of course, really excited about. And one of the reasons Debs and I were keen to share all of this with you is we are not trying to make this a Bart's health model. I think this really quickly needs to become the standard of care across the United Kingdom, and the SOPs that we have developed and delivered are lift and shift. And so we would be very happy to share this widely. And I want to take an opportunity to just thank the Ortus team, because although there are other tools to deliver this out there, this has been phenomenal. And what we've been able to achieve has been really, really important from a patient perspective. I'm aware of time and we're running late, so I know I've given you a whistle-stop tour, but I thought it important to allow others to ask questions.